So my name is Carolina Llanos. I'm from Pontificia Universidad Católica de Chile. I would like to thank the organizers for the invitation to participate in this event. Today's session is about neonatal lupus syndromes, and our speaker is Dr. Jill Buyon. She has dedicated a lifetime of work to the study of this disease. She's a tenured professor at the New York University School of Medicine and is the director of the Research Registry for Neonatal Lupus. She has contributed with very valuable clinical data about pathogenesis, clinical manifestations, treatment, and prevention. As a former fellow, I'm very pleased to present Dr. Buyon.
And particularly to thank the organizers that after a wonderful dinner last night, although I was slotted for the last day, you didn't make it at 8 a.m. Thank you. So, why you needed to stay at this meeting until the end. A 26-year-old pregnant Caucasian female who has always been healthy presents for routine ultrasound at 18 weeks during her first pregnancy. Her obstetrician finds an abnormally slow heart rate and refers her, I have to go over here?
They say they can't listen.
They say they can't listen. I mean, they can't hear? Okay. Sorry. All right. So at any rate, and here? Can you hear okay? Okay. So he refers her to a pediatric cardiologist who tells her the baby has a permanent block in the heart and may die or need a pacemaker. The young woman is told that she has an autoimmune disease, and this has caused the baby's heart problem. Faced with potential disease in herself and a life-threatening disease in her baby, she's also unsure who to turn to, since her physicians tell her the conditions are quite rare. In contrast, a 30-year-old Hispanic female who has had a previous child with a periorbital and scalp rash, which was initially considered fungal. Eventually, she was tested and found to have anti-Ro antibodies. She was told not to worry about problems in her current pregnancy. So, what is neonatal lupus? We consider it a pathologic readout of passively acquired autoimmunity, where a mother may have lupus, Sjogren's, or as we now well appreciate, be asymptomatic, but the commonality is the generation of anti-Ro or Ro-in-law antibodies, which cross the human placenta at about 10 weeks of gestation via FcRn, moving into the fetal circulation, with two main clinical features: cardiac or congenital heart block and cardiomyopathy, and the cutaneous features. Just for the record, the risk is about 2% if there's no affected child. The disease does not occur randomly, but rather at between 18 and 24 weeks. Fascinatingly, it's unique to the fetus, and as we'll discuss, is permanent if third degree and carries a high morbidity and mortality. In contrast, we really don't know the risk of the cutaneous manifestations because it's not as hard a finding, of course, as heart block. But also in contrast, the rash is rarely seen at birth, but more often at 6 weeks and UV provoked. They don't like my style. Hold on.
They gave
So,
me this.
okay.
So now, yes, you can.
Now I can move around.
Yes.
Okay. Sorry for the AV.
I'm sorry.
All right. Great. Great. Okay. It's basically the cutaneous disease that is the reason the syndrome is called neonatal lupus, because the rash is very similar to adult SCLE. But also, in contrast to heart block, the cutaneous disease is transient with very rare scarring. So today I'd like to talk about current thinking with regard to the pathogenesis, perhaps biomarkers, outcomes, treatment, and prevention. So there are challenges. We can clearly see by the frequency that the antibody alone is insufficient. And it's likely that the pathogenesis is complex, accounting for the rarity of disease. And what makes it even harder to study is that the candidate antigens are in fact intracellular. So what are these candidate autoantigens targets? 60-Ro, which I'll point out has an RNA binding domain, allowing it to complex with small RNA, and we'll get back to that point. The 52-KD-Ro has received a lot of popularity, and we'll also discuss that. It's otherwise entitled TRIM21, and it's an E3 ubiquitin ligase. Most of the epitope is centered in the area of the leucine zipper, but also notice there's no RNA binding protein. And La, similarly to 60 Rho, has an RNA binding protein. But in studying the pathogenesis, I think we'd all recognize that, in fact, tissue is the issue. And our moderator today, Dr. Llanos, wrote a wonderful paper which really gives us huge clues to the pathogenesis and treatments. And what she identified, looking at various autopsies of over 20 fetuses, that there's fibrosis of the AV node, and that's the major histopathologic finding. Also, fibrosis of the SA node and bundle of His, endocardial fibroelastosis, and valve damage are part of the spectrum of anti-Rho injury. And early deaths associated with maternal anti-Rho and LA may be secondary to a global cardiomyopathy and not simply advanced block per se. But very interestingly, mononuclear infiltrates are clearly part of the signature lesion. And this is such an autopsy, and you can see immediately in the area where there is supposed to be an AV node, in fact, it's completely calcified, and in the same area you see a mononuclear infiltrate, and notice here a giant cell. So how do we perhaps put the pathogenesis together? And this is really just a brief schema. There are data to support it, which I won't really share to you today, will be predominantly clinical, but there are two hypotheses which are not mutually exclusive, and one postulates that maternal antibodies are reactive from Rho 52 with the calcium channel on a cardiocyte. These antibodies then would inhibit calcium inward flux, or, in the hands of Marie Warren, generate a calcium overload. And perhaps that inhibition of calcium electrogenesis accounts for first-degree heart block, which we recognize as subclinical, and I'll support to you, often, or almost always, reversible. On the other hand, how do we link inflammation to the signature fibrosis I just showed you? Well, this can result in apoptosis, but another way to get to apoptosis is physiologic, as occurs during fetal remodeling of the heart. In that situation, Rho and LA may be translocated to the cell surface and complexed to small ssRNA or yRNA. And it turns out, of course, we translocate Rho and LA to the surface. This would result, one could have inadvertent binding of IgG antibodies, and this may inhibit normal clearance of this cell by a healthy cardiocyte. As such, then, we've generated immune complexes that contain both Rho and the small RNA that could be picked up in a manner very similar to the way Dr. Buzetsky described yesterday by Fc receptors and the small RNA translocated to the toll-like receptors where they're ligated, and then the macrophage may spit out pro-inflammatory and pro-fibrotic cytokines, causing the cardiac fibroblasts to proliferate, transdifferentiate into myofibroblasts with collagen release, and the scar that we see on autopsy. So genes obviously are likely to contribute to this, and this is the first genome-wide association study in heart block. And although we found an association with ERG, a transcription factor, which may relate to apoptosis, I think everyone can appreciate the heavy load that's seen in the area of the HLA, and whether or not this in these children reflects simply the mother's predisposition to autoantibody, or in the child, this generates the perfect storm. The mother has the antibody, and these actually contribute to tissue injury, can only be identified by pedigree analyses, which are currently underway. But to take this a little bit further, we can mine that cardiac GWAS and look for significant enrichment of associations of genes in pathways. And just to simplify, you can see the pathways that have been identified clearly relate to cardiocyte injury, relating to excitability, relating to fibrosis, various aspects of apoptosis. So to turn now from the pathogenesis and the genetic contribution to some of the clinical aspects. So to do so, one needs a large registry. And here I illustrate the U.S. Research Registry for Neonatal Lupus, which currently has 470 families enrolled, comprised of 587 children, largely cardiac, largely advanced block. But I'll also rely upon other registries for information from France, from Italy, from Canada, and from Sweden. So we heard yesterday an elegant talk from Levesque and Chamelot, Natalie, and we discussed the fact that many of these women only find out they have Rho antibodies because their child is diagnosed with heart block. And we ask ourselves, with these asymptomatic women, they too may be at risk for the development of an autoimmune disease. And yesterday's presentation very much paralleled work we had done several years earlier, and that is, for asymptomatic women, about 50% will go on to develop some symptoms of autoimmunity, be it Sjogren's or be it lupus, but half remain asymptomatic. And I think those factors would be interesting to identify. Likewise, the probability of an asymptomatic mother developing lupus by 10 years was only about 20%, again, very similarly shown in the French cohort. So, although not as exaggerated as SLE, gender or sex skewing towards females in neonatal lupus occurs compared to anti-Rho exposed unaffected siblings. So you can see for both heart block and rash, yes, there is a significant female predominance that's not seen in the anti-Rho exposed unaffected children. But whether this slight gender skewing contributes to the pathogenesis, we don't know yet, but I'll say something about mortality. So just a brief word on the lupus rash. Mean age of detection is actually about 6 weeks and not at birth. And the initial appearance occurring later than 16 weeks is really very unusual. The mean duration can be up to 17 weeks, and usually the rash disappears coincident with the clearance of the antibodies from the maternal circulation, which is about 6 or 7 months. Treatment generally not needed. And to show you a few examples, just a moment, the corporeal distribution is somewhat important because to call this neonatal lupus, really invariably, the rash affects the face in an annular distribution and shouldn't really be confused with a fungal rash. But you can notice that actually any area of the body can be affected. Some examples. This is obviously a baby and has a very typical owl eye appearance, and note the annularity of the lesions. Several months later, totally disappeared, leaving no scarring. But just to take pause, it isn't, as we heard yesterday, it's not always so benign. What about breastfeeding? Many of these women ask us, should I breastfeed? Will the breastfeeding cause my baby to get neonatal lupus? And in this situation, probably what we're really talking about is the development of a rash. So to assure you, as expected on this immunoblot, you can see that a mother who happened to have a child with heart block, her breast milk had the same antibody profile as her serum. So it's very clear that these antibodies are secreted into the breast milk. But the good news you can tell your moms is that based on clinical data from the registry, there really was no difference in breastfeeding, whether your child had a rash or not, and the same data were conferred recently in Marie Warren's group. So breastfeeding is not a problem, and it does not associate with an increased risk of having a rash. Now, are there predictive biomarkers in cardiac neonatal lupus? Well, there's certainly a need for such to occur. Third-degree block is permanent and usually requires pacing for life. There can be an associated cardiomyopathy, which I'll discuss, which confers a high mortality. And serial monitoring, as we all know, is time-consuming and may be costly. But what would be the obstacles to developing a biomarker? Well, the disease is rare, and antibody testing can be quite variable. But I would point out that we've all recognized for quite a long time that it's really the high titer antibodies that confers the greatest risk. But the bad news is most women who have anti-Rho antibodies, in fact, do have high titer. But this is really just validation of, I believe, what we kind of thought we knew from Canada, and elegantly done, showing us the importance of the level of maternal anti-Rho antibodies as a prognostic marker for the development of cardiac manifestations of neonatal lupus. This is their higher titer, and they do a dichotomous variable and a chi-square, and you can see that all of the children with heart block, their mothers, had high titer Rho antibodies. But obviously there's some limitations. It's only valid for this particular commercial ELISA. This method is sensitive and quantitative, but it didn't distinguish between 60 and 52, and the authors didn't account for the same mother with different outcomes. But it does reassure us that those mothers with very low titers are not likely to be at risk. So what about other candidate biomarkers? We've discussed the row 60, and I would point out that row 60 is best identified using a native antigen. And a lot of discussion occurs and centers around that, and many tests are recombinant. That recombinant row 60 is not seen as often by the maternal antibody as native. Now, row 52 is interesting, and we'll digress for a moment about it, but just to remember, it's really not row, since it doesn't contain a putative RNA binding site, and it really doesn't bind to the small ssRNA unless in complex with row 60. Now, other circulating fetal proteins have been identified in cord blood. Urokinase plasminogen activator receptor and its ligand, these were higher in cardiac NL cord bloods. And in fact, this enzyme system may lead to the activation of TGF-beta, which we recognize as a pro-fibrosing cytokine. Beta-2-glycoprotein 1, interestingly, actually binds to row 60 on an apoptotic cell and can block antibody binding, and Reed has shown that this may be is lower in cardiac NL cord bloods. And of course, another biomarker would be serial monitoring of the PR interval. So a few words about anti-Rho 52 and the P200 epitope. So anti-Rho 52 has been identified for quite a long time as an important marker in cardiac NL, and the anti-P200, the epitope that I pointed out in green, significantly more prevalent in anti-Rho mothers of children with cardiac NL versus their healthy children. And this was work done, again, from the Swedes. And then we identified that anti-P200 was found in a similar frequency in Rho mothers of children with cardiac NL versus healthy children, but others have shown that the levels of anti-P200 significantly higher in cardiac NL compared to ineffective. And really, this type of data generated an assay, or rather commercially available anti-P200. So we took a look at that, but we looked at cord blood because we thought obtaining mother's blood during affected or unaffected pregnancies and cord blood would help answer the question. And this is really how we currently test and counsel. Reactivity to P200 doesn't confer an added risk over measuring full-length Rho 52 antibodies. For a mother with a cardiac NL child, the frequency and titer of Rho 52 and P200 are not informative with regard to the risk of a recurrent pregnancy affected. Although both Rho 52 and P200 are less than 50% specific for cardiac NL, it is true that reactivity to P200 is the least often false positive in mothers who have never had an affected child. And we've all agreed that mothers with low titer anti-Rho 60 may require less stringent echocardiographic monitoring. So what about the outcomes of these children? This shows us the overall case fatality rate of about 17.5%, and about a third die in utero. Kaplan-Meier estimates, published recently in Circulation, tell us that the probability of dying in utero is about 6%. The cumulative probability of survival at 10 years for a child born alive is 86%. But there's interesting that there's a significantly higher case fatality rate in minorities compared to Caucasians. And as you can see, looking at those who died, or rather those who are Caucasian, 14% death in the Caucasians, 28% in the minority populations. So what are some of the fetal risk factors associated with mortality? I think it's important to keep in mind when a woman calls you, or an obstetrician, that her baby, her fetus, has just been identified to have heart block in utero. So from the registry, we gleaned endocardial fibroelastosis was a risk factor for mortality, hydrops, earlier gestational age of detection for the in utero death, lower ventricular rate, predictive of postnatal death. And from the European Association for Pediatric Cardiology, very similar variables, less than 50 beats per minute, impaired LV function at diagnosis, detection earlier, and hydrops. And astoundingly, isolated heart block, just say, for example, third degree, a 7.5% fatality, but if coupled to a dilated cardiomyopathy or EFE, that mortality rises to 30%. Now, most of these children do require pacing, and keep in mind about 50% are paced at birth. So where a baby is delivered can be life-saving. Unfortunately, 4 children have required a cardiac transplant, and one of our favorite families, the boy has had already 2 transplants by the age of 16. Now, what about the long-term outcome of children? This was a question asked yesterday, and I might point out something somewhat disquieting, although this is the first pass at our data from one of our junior faculty, that of 15 children older than age 20, a quarter of them are requiring cardiac medications. I think that's fairly sobering. And again, from Sweden, heart block predicts growth restriction. So what about treatments? So I'd like to begin with fluorinated steroids. And here I'd like to present what I would consider the most optimistic aspect of treatment with fluorinated steroids. And here we're referring to dexamethasone or betamethasone, which cross the placenta, unlike prednisone. And so perhaps these can be used to revert second-degree heart block to normal sinus rhythm or first degree. And looking at the same databases I've really described to you, 7 out of 20 patients, or rather fetuses with second-degree block, reversed when treated with dex versus very few that reverse second-degree when not treated with dex. So this may be encouraging, and I'll summarize this in a moment. Well, what about utilizing fluorinated steroids to prevent further mortality? And I think this is a very important question that you are going to be faced with. And the Canadians are far more aggressive, perhaps, than the Europeans, and they saw a difference, so that a 10% mortality versus 54% untreated at 1 year, and perhaps the limitation was the use of historical controls, which had higher rates of poor prognostic factors. The Europeans really didn't see a huge benefit of treatment with fluorinated steroids, but their numbers were limited to those, very few had really poor prognostic factors. So we looked at the registry, and this was actually presented at this year's ACR meeting by Peter Ismerly, and he looked at the effect of fluorinated steroids on isolated third-degree block at presentation. 152 such cases, 74 receiving fluorinated steroids, non-fluorinated steroids, and 78 receiving dexamethasone or betamethasone. And what you can clearly see is, independent of heart rate, which was somewhat interesting here, all of those with third degree survived, all of them. And this was isolated third degree block with no other signs of problems. Those receiving fluorinated steroids, in fact, there were 2 deaths. So based on this, there didn't seem to be a huge survival advantage by adding steroids to isolated third degree block. However, exposure of fluorides may improve survival at 6 months in cases where hydrops was present. And I would just point out, hydrops is nearly deadly. And you can see, of those that used fluorinated steroids, half died, but almost all of those died who were not given steroids. And I think we have to be very sobering about what hydrops means. Importantly, the addition of terbutaline did not improve survival. So what about the implications for management? In fetuses with isolated third-degree block, absent additional injury, the case fatality rate at 6 months was low, and the addition of fluorinated steroids did not improve survival, even with heart rates less than or equal to 50 beats per minute. The potential benefits of fluorinated steroids appear restricted to those cases associated with hydrops. Now, a word about IVIG, and these data come from Canada, and it's a case series of IVIG used to treat endocardial fibroelastosis, or EFE. It's 20 cases, mean age diagnosis 23 weeks, most had third-degree heart block, but some were isolated EFE, and some had myocardial dysfunction absent EFE. The bottom line is actually, in many cases, dexamethasone was added to the IVIG, and overall, 4 with hydrops died. And so the authors concluded there was a benefit because they normally saw way worse survival than 80%. But again, I think we have to accept that this isn't a controlled study in a rare disease, but something to perhaps reach for if we have a fetus with poor prognostic factors. I want to get into a minute a little bit about this PR interval measurement and go through, if you engage me, in the 3 studies that really championed the idea that we should use, whoopsie, I get very dramatic and passionate about this, that we should use this type of monitoring as a way of trying to prevent third-degree heart block. And I think we all still really are excited by this, but in fact, here are the data. From Sweden, 24 fetuses, US 98, and actually this number went up higher, but I'm only illustrating earlier publication, and the Israelis 70. So the method used in Sweden and US was a Doppler technique. The Israelis used fetal kinetocardiogram, and I don't think the details of that are particularly noteworthy at the moment for our audience. But the definition of first-degree block is pretty important. The Swedes and the Israelis used greater than 2 standard deviations, while we used greater than 3 standard deviations, and it can make a huge difference in your frequency of first degree. Notice, 33%, only 3%, but interestingly in the Israeli, 9%. For the Swedes, all of those cases with first degree were identified before 24 weeks of gestation. We'd identified 1 at 20, 1 at 22, and actually 1 at birth, which is very unusual. In contrast, the Israelis had 2 cases between 32 and 33, very far out of the window that we normally consider vulnerable, and 1 at 34. The Swedes did not treat any of the fetuses. One, who had about a 140, went on to third-degree block, and there are almost no cases of true progression and not from 3 standard deviations. 7 with first degree reverted spontaneously to normal sinus rhythm. We were a little more aggressive and treated our 2 cases that were over 3 standard deviations of 150 milliseconds. Both reverted within 7 days of dexamethasone. But in sharp contrast, the Israelis treated every case, normal sinus rhythm and all, and recommended that dex be continued throughout pregnancy. What about third-degree block in this prospective study? The Swedes found a very high rate at 8%, but these were low numbers at the time. The US 3%, and the Israelis none, because they felt they had treated all the first-degree block. But you'll notice, again drilling down in the Swedish cohort, the first-degree block at 19 weeks, which was third by 20, but this PR interval was 140. A normal PR interval in 1 went on to second-degree block by 23 weeks and normalized or reverted to normal sinus rhythm with dex. In our case, there was no preceding first-degree block in any of the cases with third degree. So how would we put this together for management of an anti-Roe pregnancy? Well, first, detailed counseling by the rheumatologist would be important. We would still maintain that fetal echoes provide information, and they provide important information. So we would do them now weekly through 26 weeks, and we might even drop the biweekly after 26 weeks. Normal fetal echoes, postnatal EKG and echo, 1 month of life and perhaps 1 year, but really a sigh of relief at that point. If the PR interval is greater than 140, i.e. 2 standard deviations, or maybe there's moderate tricuspid regurg, even in isolation, we would strongly suggest that you repeat that echo within 24 hours. If the PR interval is greater than 150, we also might suggest repeating within 24 hours to see if there's spontaneous reversal. Or at that moment, consider dexamethasone, but for a relatively short period of time. If one goes to third degree, drop the dex. If one goes back to normal sinus rhythm, drop the dex. But for alternating second to third degree, where you think maybe there isn't complete fibrosis of the AV node, one in that situation, perhaps dexamethasone has a role. If there are signs of EFE, myocarditis, CHF, or hydrops, most certainly. Complete block, though, you'll notice in white, I have no arrows. So if it's complete block without any associated abnormalities, one might do nothing but continue serial echocardiograms. But if third-degree block is associated with those risk factors I discussed earlier, that's where the most aggressive therapy, even up to 8 milligrams of dex, the Canadians, in fact, are using 8 milligrams of dex at initiation, IVIG. We've tried apheresis. I probably wouldn't really do that, but also to be very realistic with the mother, and that this baby would have a very poor chance of survival, and the consideration of a birth and then a death early in the neonatal period. So obviously, we need to ask ourselves this question, which is pretty rhetorical, right? Why embark upon a prophylactic treatment? Clearly, there is a need. And there's opportunity. The risk is identifiable. We have great databases, such as the registry and the others that I mentioned, and research clues should be translatable. So we thought we were little geniuses, and we said, gee, IVIG makes a lot of sense. So here's sort of a review of our pathogenic model, although I put out the calcium channel is somewhere over here on the slide, but certainly pertinent if IVIG might block antibody transport across the placenta, it might block FcRn, and importantly, from the work of Ravitch, it might serve an anti-inflammatory role by upregulating inhibitory Fc receptors on the macrophage that has been brought in to clean up these apoptotic immune complexes. Well, we tried, and actually we did this in conjunction with Munther Kamashta in Europe, and it was the PITCH trial, or trials, Preventative IVIG Therapy for Heart Block. Well, here's where we might have made our first wrong turn. And that is, we used 400 milligrams per kilogram. We chose that dose because we weren't really sure who we were treating, the mother or we were treating the baby. But we all would recognize that this isn't really an inflammatory dose, at least in an adult. Suffice it to say, we entered 20 patients. We had a predictive outcome of about 18% recurrence we were trying to reduce. And in the end, there were 3 cases of heart block, exactly or pretty much where we would have expected. None were preceded by a prolonged PR interval, and the study was deemed to be ineffective. In parallel, and actually at an ACR meeting several years ago, before we got these data, Munther rushed in, hugged me, and I thought, wow, this would be great. And he said, I've got bad news. We already have 3 cases of recurrence out of 15. And if we take our total, I'm eliminating 2 with rashes, 6 out of 33. Here's actually wonderful prospective study, bang on, this is our recurrence rate. And so low dose IVIG does not work to prevent the recurrence of heart block. Whether high doses would work, I really don't have any data to support it one way or another. Well, let's turn to yet another mechanism. And this mechanism now exploits the macrophage, but in a different way. Not in relationship to the Fc receptor, but rather in relationship to the toll-like receptors. And hydroxychloroquine, many of you may or may not know, it changes, it alters, it raises the pH of the endosome. And toll-like receptors require acidity to really ligate. And so therefore, the possibility would be that hydroxychloroquine might work at this level of pathogenesis. And a really interesting handshake between science and a clinician. Peter Ismaili was listening to Bob Clancy presenting some of his data where he was using actually chloroquine in his in vitro experiments, and he said, oh my, wow. And he left the room, and I saw him about a week later, and he presented these data to me. So he did a case control study. It obviously took more than a week, I'm exaggerating. And restricted, though, to anti-row mothers with lupus. And this was to eliminate confounding by indication. And his initial data supported, in fact, a decreased risk of heart block in fetuses exposed to hydroxychloroquine. And you can see the numbers here, 11% versus 31%. It gave a significant p-value. However, you know how you can lose some of your bivariates with multivariate, and in fact, adjusting for year, he lost the significance, but the trend was still in the same direction. But we asked ourselves, gee, this was lower numbers restricted to lupus. What about recurrence, where there's a higher rate? And just to remind you, perhaps for the third time in this talk, and I apologize for repeating myself, but Carolina did some very nice work showing us again, prospectively, that the recurrence rate is about 17.4%. Others have shown 16, and I showed you 18. But I want you to keep in mind that having a rash also could put you at greater risk for having a child with heart block in the second pregnancy. That's just a little side, so when you read that first slide and the mom was told, oh, don't worry, heart block's not in your future, in fact, that women may be at greater risk. But concentrate more on these numbers. So what Peter did was he then looked at the outcome of 257 pregnancies subsequent to a child with cardiac neonatal lupus, and here we called upon our international colleagues from France and the UK. And hydroxychloroquine exposure reduced the recurrence rate by 65%, 7.5%, compared to 21.2%. And this was very encouraging, and some would have said, stop here. But you know, we can't do that. But before we go on to our last study, I would also like to point out that prednisone exposure does not reduce the recurrence rate. Likewise, dexamethasone exposure does not reduce the recurrence rate. So, to end, perhaps with the beginning. Preventative approach to congenital heart block with hydroxychloroquine. So we've moved from PRIDE to PIT to patch to pitch to patch. And now we're going to talk about patch. And this is a cooperative effort of several investigators. It employs the same design as in the IVIG study. It's a Simon's two-stage with a 90% power to show a reduction of risk to 5% from 18% with two phases, so that one can reject the study, or rather the therapy, if we got 3 cases of second or third degree heart block. And our sponsors started out with the Lupus Foundation of Minnesota and now currently funded by NICHD. And here's where we're at in the study. So just to mention the inclusion criteria, the mother, of course, has to have Rho antibodies, and she must have a previous child with cardiac NL. She's treated with hydroxychloroquine, 400 milligrams, which have to be initiated prior to 10 weeks of gestation. So she could either have been on it because she was on it perhaps for her lupus, or she wanted to start it before gestation, but she really should be on it by about 10 weeks, and I would admit a few people came into this study a little bit afterwards, and we've been monitoring plaquenil levels. We do weekly fetal echocardiograms as per the physicians, and we're obviously monitoring them for PR intervals as well as cardiomyopathy. But we're also introducing a couple of biomarkers here. Peggy Crow is doing interferon levels. I have no data on that whatsoever yet, but we're also doing hydroxychloroquine levels that Natalie Costa-Doa-Chamelo is doing for us with a target, or where we don't know yet, of 1,000 nanograms per ml. And I can tell you it's very clear whether your patients are taking this drug or not. And so in our study, it's very obvious when your level is less than 300, either the mother's throwing up, putting the drug in the drawer, or whatever. But it really is a wonderful way to monitor compliance. And I can also tell you, a woman starting this drug at 10 weeks, by 20 weeks, her levels go from less than 300 up to between 600 and 1,000. So we don't know what that's a proxy of, but at least we are achieving a near target level. But I'll also tell you, in preliminary data I evaluated last night, even achieving those plaquenil levels has absolutely no effect on the anti-Rho antibody titer. And our outcomes are fairly hard, advanced block, or even an isolated cardiomyopathy. And here are the data and the current status of the patch trial. We have enrolled, our target was 19, and we have enrolled 19 mothers. 15 have completed pregnancies, and indeed, 1 case developed third-degree block at 20 weeks. And this baby has been born. No requirement for a pacemaker thus far at 3 months of age. No associated morbidities such as EFE. Our overall status at the present time is this 1 case out of 19. All 19 have passed the point of vulnerability. And although I'm excited about these data, There are caveats. Some of these women's levels never got anywhere. They threw up. So one was actually treated also with IVIG, another with steroids. So it's very preliminary data, but nevertheless, Plaquenil won't work for everybody. That's clear biology, but perhaps it is encouraging. So I would end with a translational approach to CHB. And that is a mother with anti-Ro antibodies, a prophylactic approach. Well, you might like to use high-dose IVIG to decrease placental transport or lower inflammation, but we really don't have any evidence base to suggest that at this point. We certainly would consider hydroxychloroquine because we've heard from Roger Levy and so many others about the safety of this drug during pregnancy. I would strongly urge you not to use glucocorticoids for this problem. I don't think it's effective, and we know the risks here are enormous, again, as we heard from Roger Levy yesterday. Now, between 16 weeks and let's just put this pointer at around 26, we would still do fetal echocardiograms, and in large measure, not just because of the PR interval, but looking for an isolated endocardial fibroelastosis, some change in stroke volume, something that suggests to us that something is bad is about to happen. And we would consider treatment of first or second degree heart block, but to keep that treatment at a minimum time frame and not to have it protracted for the whole course of the pregnancy. I wish, and I really didn't have a chance to share our work on TGF-beta, but obviously this may be an important cytokine with regard to the promotion of fibrosis, but we really don't have any agents there. Importantly, EKG at the minimum at birth of all anti-Ro exposed babies. And a first degree block, yes, followed by a cardiologist, because we've seen first degree block at birth, interesting, not in utero, but at birth, actually progress. And so I think there is a reason to think about this and perhaps be concerned. If normal sinus rhythm, however, and normal echoes all the way through, we would basically discharge the patient. But I mentioned yesterday that, again, from Sweden, there's a little hint of disquiet where they reported that at age 2 to 5, there were popping up some cases of first degree. But again, the clinical significance of first degree, or whether it is truly the same pathogenesis as the fibrosis that is a signature of third degree, remains to be defined. And so I think we all take great pause with Anna's quote in kindergarten, "Mommy, I don't have a heart, I have a pacemaker." And I thank all the families and all the people who've contributed to this work over the years, and really there have been quite a few. And special thanks to our team, and I think, we sort of passed the baton from Bob Clancy and I to Carolina and to Peter Ismaili. And I'll also say that when I met Carolina, I gave a talk such as this in Chile, and I think the greatest thing is she ran up to Bob and I after the talk and she said, "Oh, I'm coming to work in your lab for 3 years." And she did. And I think, sharing a sparkle of a mentor to bring one person into the fray would be a success. Thank you for your time.
Thank you very much, Jill, for this wonderful presentation. And she was a great mentor, too, I have to say. We're now open for questions. Please approach to the microphone and identify yourselves.
Thank you so much, Jill. I asked you this same question 12 years ago at this same meeting in Barcelona.
Good.
And the question is, how many consistently anti-Ro seronegative mothers...
Anti-Ro seronegative mothers, yes.
Yeah,
Yeah.
consistently.
Yes.
After, of course, using a variety of techniques. In other words, truly anti-Ro seronegative mothers with children with this problem.
So I'm going to tell you the same thing I told you 3 years ago. And I'll probably tell you this in 5 years. I don't know. And the reason I don't know is that for us, and thinking about the pathogenesis, it's sort of no antibody, no that disease. So I would acknowledge, absolutely, there are other reasons to develop congenital heart block. But autoantibody mediated is defined by an autoantibody. It's kind of like lupus, sans, and ANA. So I can't answer that question. And for us, a woman who didn't have anti-Ro antibody, by definition, would be excluded from the registry, particularly if we were looking at genetics. So while you might consider it circular reasoning, I would say it's defining a phenotype. So I think you should study that. Seriously, I feel unprepared because that's not part of what we think is the pathogenesis, so it might be a totally different disease. We once saw anti-RNP associated with a transient, abnormal PR interval. Now, that's it. So I really can't answer beyond that.
Thank you.
A Silverman from Toronto.
Uh-oh.
Hey, Jill, that was very good, as usual. As an aggressive Canadian,
Yes.
as you know, we
Yes.
believe you far undertreat your patients.
Yes, that's according to you.
I said we believe you far. We don't. We have far less deaths. We don't see high drops. But, so we do see permanent reversal. So I'm actually very surprised that even at a low dose where you've seen reversal, why
We've never seen reversible of third-degree block.
you have, but it's been transient. At least you
Right.
reported.
There's
it.
never been permanent reversal of third-degree
We have
block.
seen permanent reversible out to 3 years.
We've never.
And well,
There's
anyway,
always a rare case out there, isn't there?
And we've also significantly seen our decrease in pacemakers at a higher dose.
Right.
So, but my real question is, so then that's why you no longer treat patients. Is your new recommendation? Is that right?
I'm sorry, I can't.
So
we
your
no longer what?
recommendation now is not to treat, to prevent.
Yeah, so for us,
Yeah.
and I think everybody, and I try to give an evenness. Obviously, it would be fun to have a debate perhaps on this subject, but we don't recommend steroids for cases of isolated third-degree blocks. So we do have a different view of this. That is true. We feel that the risks outweigh the benefits, and we don't.
Okay, and final point there. We've seen those one side effect of one mother who couldn't tolerate. But Oswaldo's question, in our prospective studies, it's about 1/6 approximately of heart blocks that get referred to our center do not have anti-Ro antibodies in the mother.
Right, so I think you're dealing with a different entity.
I
and
agree
think
100.
That's exciting. So maybe that entity has a different pathogenesis than I suggested because Ro antibodies, very importantly, carry HY3, and maybe it is this ssRNA that has a major effect, or maybe there isn't cross-reactive with the calcium channel, and you know Bob Hamilton is studying this extensively in your area. It just may be a different disease. I mean, obviously, that's why even lupus could be various diseases, and I think it's important as clinicians that we precisely phenotype, and I only stand by the phenotype we've described.
I agree 100%, and just one final point. The pathology historically has been different, that develops as an agenesis of the node, not fibrosis, no calcium.
Right, so I think, again, it shows us that if we're studying a disease, especially if we're trying to couple it with the histology, that we have to clinically define our entity. And one of the interesting things about this disease is that it seems to be a disease occurring after the first trimester. And so agenesis of the node and other things, these in general, from a clinical perspective, are nodes that would have otherwise been normal before antibody exposure. So clearly, if you see transposition or other things, this may be a whole different pathogenesis.
We have one more
Jill,
question,
sorry.
Dr. Lacon.
Yeah, Jill, a nice presentation. I have a question.
Sure.
Have you actually explored further the reason for the difference in mortality rates between minorities and non-minorities?
I wish I could say the answer was yes. All I can say is that our registry, whether it's not a reflection of lupus or there's some bias, but honestly, we haven't gotten to those people well enough. And so our registry is 80% Caucasian. And I think that's a huge problem, and I can only tell you that outreach and all these things are important, and whether from a genetics perspective it will wind up being important, I really don't know the answer yet because the numbers are too small. But I would also say gender, sex, has nothing to do, or does not seem to imply or confer increased mortality. It is the minority population. I guess that's it.
Thank you very much again, Jill.